Diabetic macular edema with coexisting epiretinal membrane. Well, firstly, I'm not going to define the cases that support my side. We're going to look at averages in the field. So let's take the anti-VEGF side. So we all know anti-VEGF works in diabetic macular edema. And Solon will think, why is he starting with such excellent results from diabetic macular edema? 12.5 letters, 4 weekly, 12 injections, 10.7 letters in Vista, Vivid, 10.5, 10.7, and trials coming out of our ears, perfect trials showing 7 to 12 letters of improvement. However, that is in beautifully run trials. What about in the real world? What are we actually telling our patients? Are you telling your patients they're going to get 12.7 letters from their DME treatment, 12 injections? Well, in fact, if we look at some real-world data about how effective anti-VEGFs are in this field, and let's take this one from the United States, so it's not in Greece, it's not in Britain, published, almost 6,000 cases, as opposed to these excellent trials with a mere 400 or 450, and we suddenly look at, in the real world, our diabetic patients with not undertreated, on average 8 injections, are in fact only getting around 5 letters, which is 1 line, and sometimes with ranibizumab, only 4 letters for their 8 high-risk injections. So once again, so you've got to say to your patients, well, listen, actually, in the real world, we can't use all those beautiful studies, which are sort of masked double-blind studies. We can only tell you what happens in the real world, and it's not so good. But there's more. So if you take the real-world studies, which are only giving you really 5 letters, and you look at the effect of anti-VEGF in the presence of ERM, and I know Solon surprisingly could only find an in vitro study, but there are, of course, the in vivo study he showed, 15 eyes, DME alone versus DME with ERM, we see that there's a significant difference in the improvement in vision between presence of ERM and alone, and a conclusion that says ERM and VMA must play a crucial role in reducing the therapeutic effects of anti-VEGF agents. So remember, we're starting with less effect. Don't believe the trials because it's not happening in our clinics. And then when they've got an ERM as well, it's reduced yet again. And he says, well, that study's not very good, so let's find another study. Here's one with 105 eyes comparing DMA alone versus DME with ERM. And you see that in terms of change in thickness, there's much more than a half effect once you've got an ERM. And once again, a conclusion that ERM and VMT abnormalities significantly reduce the effectiveness of intravitreal anti-VEGF therapies in eyes with DME. So when we really look at this, although we all like to tell our patients they're going to get 12-letter improvements, in fact, in reality, we can only offer them 5 letters. And in the presence of an ERM, and I'll be generous and say it's only half as effective, we're probably only offering them about 2.5 letters for their 8 to 12 injections. And when you are injecting, you need to tell your patients that you're going to give them a long series of injections, up to 8 a year, for only 2.5 letters improvement. And this is what you've got to weigh up against the outcome of ERM peeling. And what about that? Well, let's look at ERM peeling in the presence of diabetic macular edema and ERM. So this study here, 46 eyes with ERM and DME, 38 patients submitted to vitrectomy with a 12-month follow-up. At the 12-month follow-up, a median decrease in CFT of 230 microns, and it was less than 300 in 65% of cases, so a good reduction. And if we look at the vision, an improvement of greater than 10 letters was achieved in 60% of cases and a decrease in only 13%. And also, DME recurrence was observed in only 10% of cases. So all the things we want to see. We see a good reduction from surgery. We see not many patients losing vision, and we don't see the recurrence. So here it is. We've avoided, in many cases, the need for VEGF injections, and their conclusion is PPV for tractional diabetic macular edema. We see an improvement in retinal thickening and visual outcome in more than 50% of cases. So once again, it's an effective way of treating it, relative to the relatively ineffective way of using anti-VEGFs in the presence of ERM. Now, you might say that's just a small study. Well, I too have found a meta-analysis, because of course that's much more powerful. And here is a meta-analysis, and it's used all the studies from PubMed, Embase, Web of Science, Cochrane, ScionMed. So a very large trawl through, and they looked at the clinical outcomes following vitrectomy with epiretinal membrane peel, with or without ILM peeling for the treatment of DME. They found 14 studies with a total of 857 eyes, which they felt were effective studies. And the meta-analysis came out that VA improved more than 2 Snellen lines in more than 50% of these cases, and it was even more if ILM peeling was carried out. And their conclusion from the meta-analysis was vitrectomy is effective for DME, and the effect can be improved by additional ILM peeling. This is peeling ERM in the presence of diabetic macular edema, especially for anatomical efficacy, without increasing the incidence of intraoperative and postoperative complications. So one is, I think you might find that the anti-VEGF injections alone are far less effective than you might be promising your patients based on the pure phase 3 studies, and also that ERM peeling within the context of DME has a literature that suggests it's beneficial. Well, what about the risks? Solon talks about the risks of vitrectomy, but we know with modern small gauge surgery with good systems of viewing, we have a good chance of a clean peel. But what about the chance? He puts up endophthalmitis, but in fact, the rates of endophthalmitis in vitrectomy and injections are the same. But for one, you do it once, and for the other, you do it a minimum of 8 times. So the endophthalmitis rate, although Solon will want you to think otherwise, is in fact 8 times more per year by using anti-VEGF. Stroke, hugely debilitating disease. There's no association with stroke with vitrectomy, where there is a clear association with stroke with using anti-VEGF. No association with myocardial infarct or other vascular disease with vitrectomy, where there is in anti-VEGF. And let's look at that. The VIEW study, when VIEW studies were evaluated and broken down by age, an imbalance was seen in the rate of cerebral vascular events in those over 85-year-olds. At 1 year, this was 1.2% for ranibizumab and 7% for aflibercept, and at 2 years, the rate was 3.4 and 9.5 respectively. These are significant numbers, and within the group of patients at the highest risk of stroke, those patients treated with 0.5 milligrams had a higher stroke rate versus sham with a significant odds ratio, and they comment that one of those high-risk groups is diabetics. So once again, you're choosing to treat with a drug that has a profound effect on their general health with reduced effects in real world and doubly reduced effect in the presence of epiretinal membrane, and probably, like Solon, promising them the world based on phase 3 trials without epiretinal membrane. And just remind me, when you're telling your patients, you've got to tell them that it's okay to get a stroke for 2.5 letters with anti-VEGF when they could be having a vitrectomy with no added risk. Also, endophthalmitis, incorrectly said to be a high risk for a vitrectomy. It's 8 to 12 times the risk, depending on how many times you want to inject per year, for 2.5 letters on average, relative to just 1 risk for vitrectomy. And there is no quality of life data on the difference that less than 5 letters of improvements makes, but there is good quality of life data, the effect of a stroke and a heart attack has on your patients, especially those with diabetes. So I feel that it's pretty clear cut. Those were unconvinced before. There's plenty of evidence and there's plenty of conceptual reasons to peel first, because you can reduce treatment episodes, 1 instead of 8. You can maximize outcome and the effect of anti-VEGF if you still need it. There's no risk of stroke because it's not associated with vitrectomy, no risk of heart attack because it's not a stroke. You reduce the risk of endophthalmitis because you may only treat once. And with modern narrow gauge surgery, closed system vitrectomy with modern viewing systems, it is safe. So peel first will benefit your patients because minimal treatment, minimal burden to the patient, minimal treatment, minimal risk, and minimal treatment, minimal cost. So the cost of a vitrectomy, I can tell you, is less than the cost of 1 year's course of anti-VEGF. And therefore, I come to my conclusion, which I think you've already reached before I got to the end, that of course you should think about vitrectomy with membrane peel first in combined disease. Thank you very much.
Okay, shall we just vote again? Can you raise your hands? Which ones feel that we should be treating DME first? And then perhaps doing the vitrectomy if needed, and the other way around for Lyndon. So first, 1, 2, 3, 4.
Which one's this one? That was
This-
an ambiguous question.
Okay, just put your hands
clever,
down.
you're very
Number 1 is DME first, and then
We're
vitrectomy.
both treating DME. Injections first? Or
Injections for DME first, and then vitrectomy. Number 2, there you are, you got it there. Number 2 is vitrectomy first, and then injections.
Okay. Injections first. Hands up.
Or you can vote if you like, Udi.
Okay, no, that's too complex.
That's 1, 2, 3, 4, 5, 6, 7, 10.
That's less than before. And vitrectomy first. Vitrectomy first. Look, I've transformed the lives of so many people. Solon, that's that's a victory.
It's definitely a very ambiguous result, but it's a win-win situation. So please,
It's how much you change the opinions of people.
yeah,
not-
exactly. But even if you did that, it's a win-win situation. More vitrectomies are coming in. Thank you very much. Now we're moving to the next one, and the next one is a debate between David Yorston and Dr. Potamitis.